Thank you all for coming to our beleaguered but now joyous city. We really appreciate your coming to not only this conference, but coming to support us in this really difficult time for Bostonians. My name is Mary Zanarini. I'm president of NASSPD. I'm a professor of psychology at Harvard Medical School, and I'm the person beyond our local committee who's had more emails in the last 24 hours than I've had in my life. This is the first annual NASSPD conference, and we've decided in all probability to hold this conference every year and for the next couple of years to be in Boston, so we hope to see you all again and bring all your friends and colleagues and even more colleagues. What are our goals? We want to encourage the growth of research on personality disorders by expanding the number of younger investigators, by encouraging professionals from all mental health disciplines to become involved, by convincing clinicians that research findings are relevant to their day-to-day work. It's not something somebody is doing in the corner with a chi-square and a calculator. It's really something relevant. If Marcia Linehan hadn't done the back-breaking work around DBT, or Anthony Bateman around mentalization, or Nancy Bloom around steps, there wouldn't be, or Kim Gratz in the back, there wouldn't be any manualized treatments for BPD. We'd all still be doing whatever and praying for the best. And also by welcoming patients and their family members to learn the most up-to-date information pertaining to their condition. Personality disorders, BPD in particular, have been something parents and patients haven't been told about, and they should be told about it because BPD has the best prognosis of all the major psychiatric disorders. And let me talk about a few collaborations we've had. With Perry Hoffman, the National Education Alliance for Borderline Personality Disorder, NEA.BPD, which is an advocacy group for those with BPD and their families. And they also developed a Family Connections family-to-family therapy program, a very important addition to our range of treatments. We're also collaborating with the BPD Resource Center at New York Presbyterian Hospital, Kernberg's group, Frank Yeoman's group, and we're combining our dinners at the annual meeting of the American Psychiatric Association instead of somewhat strangely holding them on the same evening and being surprised that people didn't know which one to attend. We've decided actually to collaborate. And then we also have our own official journal. It's called Personality Disorders, Theory, Research, and Treatment, better known to the insiders as PDTRT. And it's our affiliated journal published, and it's published by the American Psychological Association, and the editor of the journal is sitting in the back. And let's just talk about how far the field has come during the last 20, 25 years. And I'll just talk about a little bit about my own research quickly, because this is really, I think, simply been one of the studies, along with the collaborative longitudinal personality disorders study, or CLIPS, that's made us feel that personality disorders are a hopeful diagnosis. In the McLean Study of Adult Development, or MSAD, we found that symptomatic remissions are very common. In fact, 99% of people attain one after 16 years of follow-up. Recurrences are relatively rare, and completed suicides are only about half as common as expected. And all of these findings have been confirmed by the CLIPS study at 10 years. Now, while the symptomatic outcome for BPD looks very, very good, there are more guarded prognostic areas. Recoveries involving concurrent remission from BPD and, at the same time, good social and vocational functioning are more difficult to achieve. And that's primarily because working competently and consistently on a full-time basis is difficult for many of those with BPD. It's not that they're fired from jobs for intriguing behavior. It's more that they're so anxious and so avoidant of their anxiety they never get to the workplace. And also, their physical health can also be compromised, and that's true for a substantial minority. And it's also true that poor health is mostly in non-recovered patients. They have all kinds of medical syndromes. They suffer from obesity, which is often aggravated or brought on by aggressive polypharmacy, which has no known empirical basis, obesity-related conditions, smoking, and inactivity. Now, this simply shows time to remission and recovery, and as you can see, almost everybody has a symptomatic remission, but only 60% have recovery. A recovery is what we would all want on our CV to say we're doing well. And And so that's much harder for people to achieve. Now, we have a number of evidence-based treatments for BPD. The most well-known is dialectical behavioral therapy, DBT. Marcia Linehan started publishing on this topic 22 years ago. Mentalization-based treatment, MBT, of Anthony Bateman and Peter Fonagy. Schema-focused therapy, or SFT, which is not practiced that much in the US as far as I know. Transference-focused psychotherapy, TFP, of Otto Kernberg, John Clarkin, Frank Yeomans, Ken Levy. General psychiatric management, GPM, Paul Link, Shelley McBain, and John Gunderson is doing a complete revision of this and building upon it and going out on the road as an evangelical messenger for this. And systems training for emotional predictability and problem-solving steps, which is an adjunctive treatment developed by Nancy Bloom and Don Black at Iowa. Now, going forward, in general, I think it's true for all personality disorders, but BPD has the greatest evidence base. And I'm looking to all the young people and all of your students who are somewhere in a library coming up with a fantastic treatment for BPD. We need shorter, less costly, and more accessible treatments. Many of these treatments are really good, but almost no one can access them because it requires such skilled clinicians, and so many of them, it's simply not a possibility. We also need treatments that focus on what we've called the temperamental symptoms of BPD as well as the acute symptoms of BPD. In other words, undue dependency as well as self-harm, abandonment concerns, as well as suicide attempts. Interestingly enough, all of these comprehensive treatments really do aim at the same symptoms, and they're the ones that get people in a hospital, but they're not the ones that hold people back from having a complete life. So we need a second wave of psychotherapy development to really deal with these symptoms. Now, other key areas of investigation, we need new pharmaceutical and nutraceutical treatments. Medications can serve a useful, adjunctive, sort of small role in the treatment of BPD, but the idea, which is typical in our center and others, of adding 4, 5, 6 treatments, one for every symptom, simply costs a lot of money in terms of insurance, leads to obesity, and in general leads patients to feel that they can take a passive role instead of an active role in getting better. We also need genetic studies, which Larry Seaver, Antonia New are spearheading initiatives in that direction. Many people in the room are doing imaging studies, which are really important, and we really need to move beyond being surprised that the amygdala is involved, or the limbic system is involved in people being labile or impulsive. We really need to find a way that these tools can become ultimately diagnostic for psychiatric disorders and also as a marker for improvement. And we also need, for all of you who are trait psychologists, we need studies of the relationship between personality traits, temperament, which is a slightly different concept and one every mother in the room is familiar with because you bring home a baby who has a temperament. You haven't yet met the personality traits, but the temperament is there, calm baby, fussy baby, and the symptoms that these things underpin. I've been asked to have a few housekeeping comments. Basically, if you could turn off your cell phones, if you could also sign on the sheet for CME credits so you can get them. I also want to thank our sponsors, McLean Hospital, Silver Hill Hospital, Clearview Treatment Programs, the Menninger Clinic, and Austin Riggs Center for helping us to present this conference. And now I'd like to introduce the co-director of this conference, Perry Hoffman.